Dr. O'Neill.
Thanks very much, Roxanne. I'm delighted to be with you this afternoon. I'm a little afraid to combat Dr. Holger Thiel, who has done all of the seminal cardiogenic shock trials that's been done across the world in the last 20 years. So I will give it my best. Again, we're trying to inform and entertain. Just after we got done with the last case, I got an urgent phone call from a friend of mine who's a medical executive in a company in California. He tells me one of his employees, a 51-year-old man, diabetic, that came in 2 nights ago with an acute MI to an outlying hospital outside of San Francisco, and then started to deteriorate. They had a primary angioplasty, transferred to a larger center, and now has been placed on ECMO because he was deteriorating as in cardiogenic shock. So as we get better and better at treating STEMI, the mortality for STEMI is less than 2% now routinely across the world, across America. But the mortality for acute myocardiogenic shock really hasn't changed very much in the last 30 years. And as we get better and better with STEMI, the mortality for myocardial infarction is now largely going to be related to cardiogenic shock. So it's a very pertinent topic, and I think it's something that we all are going to have to focus more time and attention on. These are my disclosures. I want to go back 20, 30 years when we started doing angioplasty trials, and this is in the early days of randomized clinical trials in primary angioplasty. There were 4 trials: the European Cooperative Study, the U.S. trial, and another European study that demonstrated that mortality was substantially elevated when you did primary angioplasty. So this trial suggested between 1985 and 1995, angioplasty was considered a heresy. It was dangerous. It was irrational to do it. Now, I was one of the few believers that thought that primary angioplasty actually still had some benefit. And the reason was this: when we looked at what heart attacks were, is you have an acute cessation of blood flow to the heart. If you're going to fix outcomes, then you got to get blood flow back to the heart, TIMI3 flow. And you can see in this trial that in this slide that when you did angioplasty on the far right, angioplasty resulted in rates of TIMI3 flow of greater than 90% in the vast majority of cases. And with thrombolytic therapy, it was anywhere between 30 and 50% rates of TIMI3 flow. So how could thrombolytic therapy be better than primary angioplasty? And this is the thing that drove us to continue to look at this. And what I subsequently concluded is that we got those trials wrong. These trials were randomizing the wrong thing. They were randomizing a combination of thrombolytic therapy and angioplasty versus just thrombolytic therapy. And so you have to be incredibly careful when you do randomized trials. Randomized trials are great, but if you randomize the wrong thing, you set the field back for 20 years. And basically between 1985 and 2000, enormous controversy about whether or not angioplasty was successful or not. So I want to really be certain when we start doing trials of mechanical circulatory support and cardiogenic shock that we're randomizing the right question. And so subsequently in the TAMI trial and 26 other trials, when angioplasty was compared head-to-head to TPA, it was definitely superior. The rate of death or myocardial infarction was significantly better. The other thing about this trial that we learned, if you look in the middle, in the group that had the most benefit, the mortality benefit, was the anterior MI or the high-risk cases. And that makes sense. If you have something that's therapeutic, it's going to largely affect the highest risk patients and have less effect on the lower risk patients. So those are the things that we learned. You have to randomize, ask the correct question, and randomized trials for all of their benefit may lead you in the wrong direction. So now going into mechanical circulatory support, and again, I want to compliment Dr. Thiel because he's done a lot of the early pioneering work in randomized trial. The balloon pump 1 shock trial was looking at the efficacy of balloon pump. And what this to me is very analogous to the combination of streptokinase to primary angioplasty. If you want to get a patient out of shock, you have to get them out of shock and you have to support them. And if you look on the left, in compared to medical therapy, balloon pump really provided very little incremental increase in cardiac power output. And that really is the reason I think that balloon pumps were not effective. They really didn't improve the hemodynamic outcome for these patients. And then subsequently, in the randomized trial that he conducted, there was no benefit to balloon pumping. So I think he and I would both agree that on a routine basis that balloon pump really has no efficacy in management of acute myocardiogenic shock. It's really kind of astounding and aggravating to me that in the United States, 40% of doctors are still using balloon pump to manage cardiogenic shock. So either you believe randomized trials or you don't. If you believe in the trials that you shouldn't be using it, then why are you using it in these patients? And I think it's largely because they're desperate to do something to try to improve the outcome for these high-risk patients. Now, this is a patient that we treated in the National Cardiogenic Shock Initiative. A 59-year-old gentleman came in with a large anterior infarction en route to the cath lab. He had an arrest. He had no circulation. As we were doing CPR, we got the catheter in, put the Impella in, and then you can see that the patient stabilized. He had a total occlusion of the LAD, which was subsequently opened with a stenting. We were concerned that he was going to need an LVAD and all that. The patient left the hospital a week later with an ejection fraction of 52%. Now, sure, it's an anecdote, okay? But if you repeat these anecdotes, then this is now in 37 patients in the NCSI, almost 10% of our patients, they were actively having mechanical circulatory support with CPR, and they had a 68% survival. So these patients would never get in a randomized trial. And similarly, in an out-of-hospital cardiac arrest, 85% survival for these patients and 72% if they arrested in the hospital. So these patients are so ill, at least in the United States, they would never get into trials. We looked at now in the National Cardiogenic Shock Initiative, looking at the SCAI classification, a third of the patients were in stage E. These are the patients that had cardiac arrest that were just absolutely incredibly ill, and we were able to achieve a 58% survival for these patients. If you take a look then at the outcomes, and this is data that we've just presented at SCAI. If you take a look overall at the 30-day survival in patients with medical therapy in the red line, a 44% survival from the original randomized shock trial from from Judy Hockman. Survival was increased to 53% with revascularization. But then the other trials, the culprit shock, the balloon pump shock, have not really showed much of an increase in survival for patients. With the NCSI, with mechanical circulatory support with Impella, we've been able to achieve the survival up to 77% for Class D and Class C and D, and 68% for all comers. So I think that this shows that the survival is going to get better. We know how to use this device better. We know how to properly alter pharmacologic therapy and specifically use these support devices with right heart catheterization. So now I think it is time, and we are ready, and we are going to be doing a large randomized trial. Greg Stone, Naveen Kapoor, and I are going to be heading the RECOVER 4 study, which will be a head-to-head comparison. But I'm confident based on this data that outcomes are going to substantially improve. We've had 40 years of therapies for cardiogenic shock, and we've kind of been stalled at a 50% survival for the last 30 years. So I do believe that mechanical circulatory support is going to improve the outcome for these patients. Thank you very much.